Good morning, everyone. I'm delighted to introduce you to Professor Sathish Srinivasan. Sathish and I have known each other 25 years now, probably.
Sadly.
And you've still kept your hair. I obviously haven't. The topic of the talk today is obviously about Eagle and DSLT, but I just wanted to say a few words about Sathish first. We've got Sathish is renowned as a corneal and refractive cataract specialist, but sees all sorts of, and he's really I think one of the pioneers for us in Europe in terms of using DSLT. Based in Ayr, so if you know Scotland, Glasgow, and turn left and go to the sea, beautiful part of the world. And yeah, thank you for turning up today and coming to talk to us about your experiences with DSLT.
Great. Thank you, Andrew, and thank you, Nancy, for having me. Thanks for your interest, guys. I'll give you a quick overview of the Eagle device, and then we'll present a couple of cases, and then we'll just keep this informal. And feel free to ask me any questions or stop me halfway. I think there's been a fundamental change in the way we approach patients with ocular hypertension and glaucoma. Not very often ophthalmology articles gets published in journals like Lancet. So this is one of the pivotal studies, which is called the LIGHT trial, which was done in the UK, which clearly showed for the very first time that in patients with both ocular hypertension as well as newly diagnosed primary open-angle glaucoma, selective laser trabeculoplasty is as good or if not better than starting them on medical therapy for newly diagnosed patients. So since this pivotal study came about 4 years ago, both the National Institute of Clinical Excellence, which forms all the guidelines in the UK, as well as the European Glaucoma Society, have revised their guidelines, and now SLT is recommended as the first-line therapy for patients with primary open-angle glaucoma. So this has been a very strong evidence-based study and the evidence-based change in the management protocols, both in the UK as well as in Europe. I will not talk more about this device as people would have talked to you about this, but it's pretty much delivers same amount of energy like a traditional SLT, which you do in a contact mode by putting a contact lens in the eye and delivering the energy through a slit lamp. So this is the non-contact version, which is called the Eagle, which delivers the same amount of energy in literally about 2 seconds. You can treat either 180 degrees or 360 degrees. Hopefully there should be a video as we present. So now I've gone up to doing about 30-35 eyes. So this was a slide which we did for the winter ASCRS meeting in Frankfurt in February. So I'll just present this one case which shows how this new device can be incorporated into your practice. So this is an 80-year-old female which was first referred to me as a suspect glaucoma patient. Ocular history, she had a branch vein occlusion in the left eye, 2016. There's a strong family history of glaucoma. So uncorrected visions were okay. Applanation pressures were 26 in the right, 24 in the left. Gonioscopy showed open angles. Fundus examination showed 0.4 cups, and the nerve fiber layer OCT showed superior nerve fiber loss in both eyes. So these were the pressures prior to the visit to my office. This was the pressures from the referring OD. As you can see, the pressures, the right eye ones are in yellow and the left eye ones are in November, or the left eye ones are in green, and that's starting from October 22 to July 23. As you can see, the pressures have been hovering up in the quite high 20s. So the therapeutic strategy was initially, we started her on monopause because at that time we didn't have the SLT device with us. Pressure control was not good, so we changed her to dual therapy with Tapticom. That was not working very well, so we added a third medication, which is iopidine. And then we had to add oral acetazolamide as well. That kept the pressure down, so 3 topical medications and then oral Diamox as well. So that was the strategy. We decided to talk about SLT. At that point, I had access to the DSLT device. So we did treat all the 360 degrees. This is a big fundamental change in people who have been doing SLTs. You will be aware that treating 360 degrees with the contact lens on a slit lamp takes much longer. And usually we traditionally treat patients 180 degrees first, see the response in 4 or 6 weeks, and then bring them back and do the remaining 180. But with this device, because it's so quick, so fast, and so easy to do, we always, at least I always do, and most of the people who use this device, we all tend to do all the 360 degree at one go. That's the post-op within 6 weeks. You can see the pressure drop quite significantly, and then that continues to maintain, and the patient has been taken off, pretty much weaned off from Diamox, and then slowly weaned off every topical medication. So that's the device, and you can do it both with the patient sitting down as well as with the patient standing. I feel the patient standing is much more comfortable for them. They also feel it's less threatening and it's much easier for them. And that's the device, that's the interface where we select the eyes and then we decide whether to do 360 or 180 degrees. So that's the device getting primed, making sure all the 360 degrees of the limbus is exposed so that the speculum is not coming on the way. And then we always start the treatment at 3 o'clock and come back to finish at 3. So before you blink your eyelid, the treatment is done. And that tells you the amount of energy delivered, and you can print it off. It's electronically connected to your EMR as well, so you can print off the treatment sheet and you can electronically put your signature in, and then it gets filed into your EMR or into your paper copies. So I think that's pretty much the device and a little bit of overview. I think I'll be more interested to take questions and have some discussions.
Any trouble with prominent brow patients?
Yes, good point. The prominent brow may not be a problem, but small eyes, narrow palpebral fissures, the key is to get the right speculum. I think the company has been trying different speculums, so I think it's a balance between getting the right speculum, making sure that the superior limbus is exposed, because if the lid speculum comes on the way, the optical device, if it doesn't capture, it's like firing your excimer laser. If you don't have a clear capture of the 360 degree limbus, then you'll have a problem. So there are a few practical tricks on expanding the speculum a little bit so that the memory is a bit more relaxed. You could try different speculums, but I think the company has gone through several trials. The one which we have seems to reasonably work, but sometimes there is some practical difficulties of trying to hold the upper part of the lid up so that the superior limbus has got a good exposure.
Yeah, the great thing about being a startup too, we've been able to take some of the early feedback from the doctors, and although we've got a speculum that's working very well, we've actually got a new next generation version with a slightly smaller radius of curvature on the blade itself to help with small eyes, and it's feedback from early doctors like Sathish that allows us to do that. So we're in process to go to the next generation there as well.
It's the question of getting the right balance. You want the speculum to be quite light and not heavy, because patients are either standing or sitting, so they don't want it to pull down. But at the same time, you want a speculum which has got good memory, so that it will give you good exposure. So.
Can you tell me, Sathish, a little bit about the patient experience? What is it like? What's their experience? Has this improved your practice?
Certainly, it has helped. Certainly, it has helped the decision-making process. So now I am offering SLT as the first line, and patients are almost amazed because they've never heard of it. They're referring ODs or the referring doctors have said it's going to be treatment with drops. So I think it's kind of a paradigm shift. Once offered, patients like the idea that they don't have to use the drops. It's a one-off laser with a very little chance of getting repeated. It's almost so simple that you err on the side of, am I going to trivialize this procedure because it's so easy to do and so simple to do. So compared to the SLT, especially patients who had the traditional SLT in one eye can't actually believe how quickly this is, because they always relate it to the first previous SLT. But certainly it has helped even the patient flow in the clinic, because if we see a patient, we have a chat with them, and if they decide to do it, we are in a position to do it straight away at the same visit, rather than trying to reschedule and bring the patients back. Because the machine is always plugged in, it's already kind of pre-warned, so it's very easy to fire it up and do it. Literally takes 5-10 minutes. You can easily fit it into your schedule. even though you don't know whether that patient is actually going to have the treatment on the day.
Sathish, you've mentioned you've taken DSLT on for first line, but two questions for you, just to finish off, unless there's any other questions from the audience. What's been your motivation of using DSLT versus medication? And what's the feedback been from the patients and your staff in terms of the implementation of having Eagle in and having DSLT as a first-line therapy?
Yeah. The first motivation was because I'm a corneal specialist. We see a lot of ocular surface problems from the preservative issues with the medications. So both in my university practice as well as in my private practice, I have loads of patients with ocular surface issues. So my fundamental shift has been, if we can avoid medications, particularly in this group of elderly patients with glaucoma, I think that's where my rationale of trying SLT, especially the DSLT, has been. And since then, once you start offering it to patients, it's a much easy sell and much easier insight. Like, I would prefer a single non-contact intervention given to me compared to, do you want to use drops for the rest of my life? This is a no-brainer. Once you start offering it to patients, it's the question of the ODs getting familiar, the referring doctors getting familiar. Once you start that conversation, it becomes a no-brainer to everybody. So it's much easier than what I thought it was to convince patients to consider laser as a first line of therapy. I've got also a subset of patients who have been on 2 or 3 medications with ocular surface issues, and then when you offer SLT as an opportunity for them to reduce their medication, they jump on it, because now they have realized all the pain and the discomfort and the red eyes they are going through with 3 or 4 medications with the preservatives.
Okay, any other questions from the audience? I'd like to thank the audience too. So, Sathish, thank you for taking time
Thanks
out.
for having me.
I know you ran here from your training session. You've probably got another one to run to now. So
Thank you. Thanks for having me.
Yeah.
Thanks, everybody.
Yeah. Thank you.
Thank you.